Good afternoon, everybody. Thank you for joining us for today's presentation specifically for healthcare providers who are authorized to treat workers' compensation patients. And today we are going to share the latest updates on several initiatives that are helping to make the board better for healthcare providers and the workers' compensation system overall. I'm Adam Rossi from the board's Branding and Stakeholder Engagement Unit. You may have previously known us as the Communication and Outreach Unit. Same deal, just a different name. And joining me today, we have members of our medical director's office. We have Dr. James Tachi, the board's medical director. And also on hand are Audrey Cunningham, Paula Rauch, and Christopher Failing. And they are going to be answering your questions today. We will be using the chat feature to receive your questions. If you look on the bottom right-hand side of your screen, you'll see a little chat bubble icon. Just click on that and you can enter your question at any point today during the presentation. We will be holding off until the end of the presentation to answer any questions, however. So don't think we're ignoring you if you put in a question now, we're not answering it. We will get to all questions at the end of the presentation. Our medical director's office team will answer as many of your questions as they can, but if you have questions that we either don't get to today, or if you think of something after the session ends, we will be providing you with resources at the end of the presentation. Also, I want to point out your name and email were given to us when you registered for this session. However, if you have a topic you'd like to discuss more deeply with the board, please feel free to put in that question or that topic along with your name and email so that we can make note of it and someone can get back to you. With that, though, we are going to get started on today's presentation. But before we do that, I, as always, want to thank you for choosing to treat injured workers in the New York State workers' compensation system. Today is Valentine's Day, so I would like to say that we do love our authorized providers. Ha, ha, ha. I cracked myself up, folks. But anyway, having more treating providers means that New York's injured workers have more options, as well as better access to high-quality health care. As you may be aware, the board has been working toward making the workers' compensation system better for injured workers, better for businesses, and better for healthcare providers through several modernization efforts that improve stakeholder interactions within our systems. Over the past few years, we've undertaken several initiatives to improve healthcare and enhance the experience of treating providers. We continue efforts to make it easier than ever for board authorized providers to be part of the workers' compensation system. We truly are working to take the comp out of complicated, and we will continue to share progress with you and ask for your feedback and input as we move forward. During today's session, we'll start off by reviewing what you can do as a board authorized provider in the New York State workers' compensation system. We will then share some exciting news on the workers' compensation fee schedules, and we will also be reviewing updates on telehealth, which recently became a permanent part of the workers' compensation system. Following that, we have a few new updates on Onboard, the board's business information system. We'll touch on the New York Workers' Compensation Board's New York Medical Treatment Guidelines, also known as MTGs, and the trainings that are available. We'll then briefly update you on the board's transition to the Universal Billing Form, CMS 1500. We'll then remind you about some things to be aware of regarding workers' compensation and COVID-19, and then share some helpful resources that are available to you on all of these and other topics. And again, we will leave time at the end of the presentation to answer any questions or review any feedback you may have. To start, however, we would like to highlight what board-authorized providers can do within the New York State workers' compensation system. This chart on your screen highlights which types of treatment that each provider can provide. This chart was recently updated to include telehealth treatments, which I mentioned we will review in a little bit. And you can view this chart on the expanded provider law section of the board's provider page at wcb.ny.gov. We would like to let you know that the board recently updated the New York State Workers' Compensation Durable Medical Equipment Fee Schedule, also known as the DME fee schedule. On December 8th of 2023, The chair proposed amendments to sections 442.2 of Title 12 in the New York Codes of Rules and Regulations to update the official New York Workers' Compensation Durable Medical Equipment Fee Schedule. The notice of proposed rulemaking was published in the December 20th, 2023 edition of the State Register. Comments on the proposal will be accepted for 60 days after publication, and you can submit your comments by emailing regulations@wcb.ny.gov. The board also plans on updating the New York State Workers' Compensation medical and dental fee schedules within the coming months, so please stay tuned for updates on those. Back in July, telehealth became a permanent part of the New York State workers' compensation system following the adoption of a regulation that was many months in the making, with several iterations and rounds of public comments. We are very happy to now have this in place, but I'll briefly share with you how we got here and what it means for U.S. providers. In New York State, telemedicine was an option before COVID-19, but it was limited to phone calls to discuss test results in lieu of an in-person visit and within a finite time window. During the pandemic, emergency telehealth regulations significantly increased the permissible uses of telehealth on a temporary basis to ensure continuity and access to care. Emergency regulations were extended multiple times. A 2021 study by the Workers' Compensation Research Institute found that telemedicine is changing the way healthcare is delivered on a national level. As of the first quarter of 2021, use of telemedicine for evaluation and management services, also known as E&M services, was still higher than prior to the pandemic. However, post-pandemic, physical medicine visits have returned to near pre-pandemic levels. Costs for services that were delivered both via telemedicine and in person were generally similar. The number of visits per patient when telemedicine was present, relative to only in-person care, was larger when follow-up visits were a mix of telemedicine and in-person services, and smaller when all follow-up visits were delivered exclusively via telemedicine. The board's permanent telehealth regulations have gone through several iterations with extensive stakeholder input, and the new permanent telehealth regulations took effect on July 11th of 2023, following the expiration of the last set of emergency regulations. Now let's dive into some of the details surrounding these new permanent telehealth regulations. The newly enacted New York State regulation states that telehealth appointments may be performed by physicians, podiatrists, psychologists, nurse practitioners, physician assistants, and licensed clinical social workers through two-way audio and visual or audio-only communications. The provider must also be available for an in-person visit within a reasonable travel time if necessary. An in-person visit may be required as specified in the medical treatment guidelines or based on the clinical age or stage of the condition as follows. For MDs, DOs, DPMs, NPs, and PAs, it would be the initial visit, every third visit, acute and subacute, every 3 months if chronic but not at MMI, or annually if chronic and at MMI. For psychologists and licensed clinical social workers, telehealth should be permitted to the first and subsequent visits, including group therapy, irrespective of clinical stage of the condition. Remote behavioral health visits should be limited to situations when there is no benefit to in-person services versus remote services, or when an in-person office visit poses an undue risk or hardship on the patient. The reason for the use of a remote telehealth visit should be documented with each use of a telehealth visit. Treatment may not be rendered via telehealth for chiropractors, acupuncturists, physical therapists, or occupational therapists. Telehealth appointments that have been scheduled prior to the effective date of this permanent regulation do not need to be changed to an in-person visit in order to conform to this regulation, and the use of telehealth should not be the sole basis for challenging the results of such visits. However, any appointments scheduled after July 11th of 2023 must conform within this regulation. The regulations also delineate various clinical scenarios that indicate an in-person exam may not be necessary, such as a routine follow-up appointment after a comprehensive initial in-person exam has already been conducted, or to discuss test results and or counsel on clinical opinions, and when an in-person exam is necessary, such as to perform procedures, emergencies, eye conditions, nuanced or complex issues, etc., or when an in-person physical exam might reasonably impact the accuracy, quality, or certainty of the assessment, treatment, or recommendations. Some scenarios do require an in-person visit. They include, but are not necessarily limited to, urine drug testing, appointments to determine permanency, impairment or disability, initiation of a chronic medication, or if the patient lacks the technology, capacity, or the desire for telehealth visits. We are frequently asked whether independent medical exams, also known as IMEs, can be performed via telehealth. It should be first noted that technically IMEs are not considered treatment. So with respect to performing IMEs remotely or virtually, this is permissible if all parties agree, and if the IME is not being performed to determine permanency or permanent impairment. As I mentioned, these regulations did go through several iterations, incorporating extensive stakeholder input, so we do believe that these newly enacted regulations strike an excellent balance of that input. As I mentioned earlier, the board is working towards making it easier than ever for board authorized providers to be part of the workers' compensation system. That's why we are very pleased that the first phase of our new business information system onboard, one of the largest modernization efforts at the board to date, has been fully live for just over a year and a half now. Since its launch, more than 1.5 million PARs have successfully flowed through our system. Today, healthcare providers and insurers are using Onboard to request and review prior authorization requests for medication, DME, and testing and treatment and testing. And we have hundreds of these PARs successfully flowing through the system each day. Nearly 54,000 healthcare providers have registered for Onboard, and more than 41,000 delegates have been added. 100% of medication, behavioral health, and DME PARs have been resolved within 3 days, and most other PARs are resolved within approximately 30 days. Approximately 95% of these are resolved at the level 1 or level 2 stages of review, meaning without escalation. Over the course of the year, the board has made more than 66 system enhancements in direct response to feedback from healthcare providers and other users. So we want to thank you for that. We always appreciate your input. And lastly, some good news here. As we all know, the board has now reduced the backlog of level 3 PARs reviews from over 8,000 down to 0. Over the past year and a half, the board has been steadily working to reduce the level 3 PAR review backlog, using data to identify problem areas, implementing new processes, and adjusting staff resources. And thanks to this effort, every level 3 PAR review is now handled within 2 to 3 weeks. As I mentioned, Onboard has processed nearly 1.5 million PARs. So here's a quick breakdown of all PARs submitted to the board at this point. And we want to note the submission of MTG confirmation PARs is completely optional for healthcare providers. Treatment for a given condition that a provider knows to be specifically recommended by the MTGs is pre-authorized and does not require a confirmation PAR, except for those relatively few special services for which a special service PAR is always required. So, how has Onboard made workers' comp better for providers? There are several benefits which we will now discuss here. Onboard provides increased accuracy, paperless transactions, and a user-friendly interface for interacting with insurers and the board. Healthcare providers can now request board action on unpaid medical bills through the submission of the Request for Decision on Unpaid Medical Bills, known as Form HP 1.0, to ensure accuracy and timely receipt. Electronic submission of PARs for treatment, medication, and DME. PARs for complicated and or invasive medical procedures, such as special services PARs, may also be submitted. Onboard eliminates the confusion on which forms to use, and all submissions are automatically routed to the correct party with a time and date stamp, so there are no more wrong fax number scenarios. We also want to note that the new DME fee schedule did become effective with the launch of Onboard limited release back in March of 2022. Within Onboard, authorized providers can assign delegates, such as your office support staff, to help you work within the system. Assigning delegates can assist you by drafting and submitting PARs, monitoring provider onboard dashboards and insurer responses to PARs, drafting and submitting level 2 medication PAR escalations, drafting and submitting PAR escalations to level 3 for medical director's office review, responding to insurer requests for information, and drafting and submitting Form HP 1.0. As of February 8th of 2024, you'll see that now delegates can submit for PARs and escalate level 2 medication PARs for review. You may have known previously delegates were only able to draft both, but were unable to submit or escalate. Please note, however, the board strongly advises against a pharmacy employee, DME vendor, or medical supplier serving as a delegate of the provider or prescriber to prepare PARs. We believe that for most workers' comp prescriptions, the prescription writing is outside the scope of practice of a pharmacy or a medical supplier or vendor. Moreover, even if it were within the said scope of practice, we fail to see how the pharmacist or the supplier or vendor would have enough direct knowledge and understanding of the patient's clinical history and status, or direct access to the provider or prescriber to appropriately recommend and or provide medical justification for the PAR. Finally, we believe that such a relationship runs a very real risk of the pharmacy or the supplier or vendor and the provider or prescriber from running afoul of state and federal anti-kickback laws. You can visit wcb.ny.gov/onboard to view a registration guide for healthcare providers under the Training and Resources section. We would like to note now that delegates cannot do the following. They cannot accept the XML submission partner, known as an online submission partner agreement, register with the medical portal, or report on a provider's status. The board has also introduced updates for Form HP 1.0 submissions. As of February 8th of 2024, the attestation required as part of submission of Form HP 1.0 has been updated. Also, previously in Onboard, Form HP 1.0 submissions that are flagged as a duplicate present a warning message to users. This warning message alerts the user if the Form HP 1.0 was previously submitted for the same dates of service. Users can continue to submit the form regardless of this warning. To prevent duplicate submissions, a new alert will appear for users attempting to submit a duplicate submission. The first alert will flag that this may be a duplicate submission. Users can select OK to continue with their submission if needed. If it is a duplicate, users can select Exit to return to the dashboard. The board has also updated the medical billing disputes section of the website to outline required documentation, the arbitration process, arbitration scenarios, and recommended actions for both payers and healthcare providers, FAQs, and more. On the board's website, you can visit the provider quick link at the top of the homepage and then select medical billing disputes on the billing card to view these updates. Once your PAR is submitted, the insurer has a set number of days to respond. Response requirements vary for certain PAR types. Responses for MTG confirmation are required within 8 business days. MTG variants and MTG special services responses are required within 15 calendar days, but the response time is extended to 30 days if an IME is requested. Non-MTG over $1,000 responses are required within 30 calendar days. Non-MTG under or equal to $1,000 responses are required within 8 business days, and medication and DME responses are due within 4 calendar days. Of note, for medication and behavioral health PARs requiring level 3 review by the MDO, the overwhelming majority of these are resolved within 1 to 2 business days, and all are resolved within 3 business days. Please note that there is some variation on response times with weekends and holidays, and you can visit the board's website at wcb.ny.gov/onboard/providers, and you can see the PAR review section in the overview tab. You can also view this chart that you see on your screen now on the provider overview page at wcb.ny.gov/onboard. Now, we are often asked how providers can expedite the PAR process. Here are a few helpful tips to receive a timely response for your PAR. You can submit the correct PAR type, it's number 1. 2, submit supporting documentation, which includes any relevant diagnostic imaging and or testing reports with the original PAR submission, and do not merely refer to their medical record. Use the MTG lookup tool located in the medical portal, or you can search, cut, and paste your MTG reference for the requested clinical intervention and include a copy of the result with your PAR. You can check or have your delegate check the onboard dashboard regularly for insurer responses and request level 2 and level 3 reviews in a timely manner. Also, respond timely with additional information when an insurer initiates a request for further information, also known as an RFI, within the system. Include a clear clinical rationale for the request in the medical narrative section, clearly stating why a variance from the MTGs might be necessary. Also, when escalating a PAR to a level 3 MDO review, include a rebuttal that addresses the insurer's level 2 denial rationale in the escalation reason field, rather than simply copying and pasting previously provided clinical. Use appropriate MTG reference codes and only use none when the MTGs do not address the specific treatment being requested. Include the frequency and duration, if applicable, for the proposed treatment in the medical necessity field, and if the request is for post-operative therapy, include the date of surgery. We are happy to note that the frequency and duration are now available as drop-downs when the physical modalities are selected. Lastly, we would like to remind you that it is important to keep your information up to date with the board. The board does not distinguish between never authorized providers and those who lapse in authorization. Healthcare providers must renew authorization every 2 or 3 years. At the same time, you renew your registration with the New York State Education Department. However, this is a separate and distinct process, and sometimes things change during that time period, such as your address or your phone number or your email. So we want to make sure that's all updated. So to do so, you can log into the medical portal, and under the medical providers section, select either new provider authorization request, authorization renewal, or update authorization information. In May of 2022, the board updated all existing New York medical treatment guidelines, also known as MTGs, and new MTGs were also added. Any newly authorized providers that are on with us today, here's some quick background on the MTGs. In December of 2010, the board implemented legislatively mandated MTGs that fundamentally changed the delivery of healthcare to injured workers. The MTGs initially included 4 evidence-based guidelines for the treatment of injuries involving the neck, back, shoulder, and knee. These became the mandatory standard of care for dates of service on or after December 1st of 2010. On March 1st of 2013, the carpal tunnel syndrome MTG and updated versions of the then existing MTGs, including a new maintenance care program, were adopted. The non-acute pain MTG, as well as the updated versions of the existing MTGs, were implemented for dates of treatment on or after December 15th of 2014. You can also find links to MTG trainings currently available for medical and non-medical professionals. We are pleased to share that CME trainings are once again available for credit. In collaboration with our new accreditor, the Medical Society of the State of New York, the board has updated all existing training modules and completion certificates. For a bit of background, each of these 16 MTGs has an associated online training course, enabling you to take courses you want when you want them. Each training provides an overview of the general guideline principles, conditions associated with the body part or disease, and treatment recommendations. As an added benefit, there is opportunity to attain complimentary CME accreditation upon completion of each course for those who qualify. There are also non-CME trainings for staff who would benefit from these trainings, but do not need or qualify for CME credits. To access the trainings, you can visit the board's website and navigate to the healthcare provider section in the middle of the homepage. Select the medical treatment guidelines link, and from there you can select the training link on the right side of the page. The MTGs effective for treatment as of May 2nd of 2022 are listed right here on this slide. Please visit the medical treatment guidelines section of the provider page on the board's website for more details. You can access full details on the new and updated MTGs, including a fully searchable and cut and pastable PDF of the respective MTGs on the board's website. Select providers at the top of the homepage, scroll down to resources, and select medical treatment guidelines under the treatment section. And just a reminder about the availability of the MTG lookup tool in the medical portal. This tool allows users to quickly determine whether a particular condition or treatment or test combination is recommended, not recommended, or conditional according to the MTGs. This does not constitute a prior authorization, but it can be submitted as part of the PAR process. When a treatment or test name is selected, the relevant section of the full MTGs for that condition will display. This online tool will help speed treatment decisions and ultimately provide more effective and efficient care for injured workers. The MTG lookup tool also has a feature for use by providers that produces a verification summary document in PDF form that confirms a lookup was completed, provides treatment recommendations for that condition, and displays patient-specific case information. This document can be kept by the healthcare provider or attached to any request for service, for example, as I mentioned, a PAR, or a medical bill being sent to an insurer as verification that the treatment adheres to the recommendations set forth in the MTGs. The MTG lookup tool is available for all MTGs, and you can access it in the medical portal by going to the board's website, select the medical portal from the online services menu at the top of the homepage. As the board continues modernizing and improving stakeholder interaction within our systems, we now want to look back on our official transition to the CMS 1500 form, which is the Universal Medical Billing Form, which was implemented over a year and a half ago. Since July 1st of 2022, the board has received nearly 1 million CMS form submissions, including nearly 3 million electronic submissions through an online submission partner. More than 11,000 providers have submitted their CMS 1500 forms electronically through an online submission partner. The board transitioned to the universal form to reduce the administrative burden on participating providers who previously had to use separate board-specific forms for the workers' comp patient. Since July 1st of 2022, healthcare providers have been required to use the CMS 1500 form for all workers' comp medical billing. Electronic submission through an online submission partner is strongly encouraged, although it is not currently required. As part of the initiative, use of the prior medical billing reports, including the doctor's initial report, which is Form C4, and the doctor's progress report, which is Form C4.2, have been discontinued. Providers must also prominently report the injured worker's temporary impairment percentage, work status, and the causal relationship of the injury at the top of the CMS 1500 form medical narrative. We want to note that provider types who are not permitted to opine on causal relationship or level of impairment are not required to submit this information. The medical portal provides access to all the online services the board offers, including electronic submission of medical bills to insurers and the board. Once you have accepted the terms of XML submission agreement, you can then discuss details of submission with an approved online submission partner. After logging into the medical portal, providers who have not already signed up for the XML submission agreement of the CMS 1500 will see a link for Agreement for XML Submission of CMS 1500 under the Billing section. Select that link and then select the I accept button. The provider's name will be added to the listing of providers authorized to submit XML data, which we update daily. And once this is accepted, that link will no longer appear when you sign in again. For ease of bill submission, the board strongly encourages electronic filing of all CMS 1500 forms. This can be done by partnering with an online submission partner. The online submission partner will ensure that the medical bill and narrative attachment are sent and accepted by the correct insurer. If partnered with an online submission partner, providers do not need to complete a CMS 1500 form, but rather submit the bill and narrative attachment to the online submission partner, and they have a relationship with the agreed upon format. The online submission partner will forward the bill and the narrative attachment to the insurer. The insurer will then accept the CMS 1500 form from their online submission partner and will return electronic acknowledgement of receipt. The online submission partner will then forward the acknowledgement, including the receipt date, to the provider. Online submission partners will transmit in the designated XML format the billing data, including the payer's acknowledgement of receipt, the CMS 1500 forms and narrative attachments, payer's acknowledgements of receipt to the board, and the CMS 1500 forms and narrative attachments received by the board will be combined and displayed in the applicable injured workers WCB case folders. Please note, when CMS 1500 forms are submitted to the board using an XML submission partner, providers should not mail, fax, or email a duplicate paper form to the board. So we'd like to take a minute now to highlight the benefits of electronic submission. Again, we are strongly encouraging this if you're not already. First and foremost, providers, you're going to get paid quicker, typically. When a provider submits a CMS 1500 form electronically, the online submission partner will submit to the insurer and to the board. Providers will have confirmation within 7 days that their bill was accepted or rejected by the insurer. With acknowledgement of receipt from the insurer, the provider is aware that they should not resubmit the bill. Technical errors are identified quickly, so they can be corrected and resubmitted instead of waiting for the insurer to deny the bill. And lastly, as I previously mentioned, submitting electronically makes the billing process much easier for you. There's no need to submit the CMS 1500 form separately to the insurer and the board, and there's no more paper involved. When the medical narrative template is used, providers must attach a narrative report with clinic visit history examination findings, including the history of the injury or illness, any objective findings based on the clinical evaluation, the diagnosis and assessment of the patient, and the plan of care. Just noting here, this really is no different than the minimum standard of care requirements for documentation of any clinical encounter, whether it be workers' comp or non-workers' comp. The board has developed a medical narrative template that can be used to create a medical narrative report that accompany most provider submissions of the CMS 1500 form. Template includes the 3 elements to include with narratives, including the patient's work status, causal relationship of the injury or illness to the patient's work activities, and the temporary impairment chart percentage. It is imperative for providers who are expected to do so to include these 3 elements to ensure workers receive the treatment and indemnity benefits they are entitled to, and for prompt payment to the provider. The medical narrative report may be found legally defective if these elements are missing. However, insurers should not use this as the sole basis for non-payment, especially, for example, if an injured worker with a long-term condition is not working, is at MMI, and has an unchanged level of impairment, and the provider simply documents clinical, occupational, and functional status unchanged from the last visit. It is important to note that certain provider types are not permitted and therefore not required to provide impairment percentages or opinions on causal relationship. A PDF of the report can be found at wcb.ny.gov/CMS-1500/requirements under the medical narrative requirements section. For certain types of medical services or supplies, a medical narrative is not applicable. Instead, an attachment is required. So, for example, a radiologist should submit the radiological report with the CMS 1500, and a DME supplier should submit the physician order with their bill. A full list of attachment examples may also be found in the requirements section of the website. Although Form C4.3 is not being replaced with the CMS 1500 form, the CMS 1500 form can still be used by medical providers who are submitting electronically. However, there are specific guidelines which must be followed when submitting medical bills for permanency evaluations. It is very important that medical providers use either CPT code 99243 or 99245 for permanency evaluations. Code 99245 is used for examinations and reports of non-scheduled permanency evaluations, and 99243 is used for examinations and reports of scheduled permanency evaluations. When using either of these CPT codes, they should be the only code billed for the CMS 1500. A completed Form C4.3 should be attached to the CMS 1500 form as the medical narrative attachment. Finally, when billing electronically for permanency evaluations, it is not necessary to separately send Form C4.3 to the board. All right, so lastly, we want to make you aware of the resources we've been sharing with injured workers who believe may have contracted COVID-19 in the workplace. While the incidence of new COVID-19 cases are not as severe, we do continue to get COVID-19 claims coming through, so the information is still important to share. The board strongly encourages workers to file a claim if they believe they contracted COVID-19 at work. However, the insurance carrier must notify the board of the incident. Workers have 2 years from the onset of illness to file a claim, and a positive PCR test is required. The board has been holding free informational webinars to the public on this topic. We had been doing them monthly during the height of the pandemic, but we've since scaled down to hosting them about every quarter. Our last webinar was just last month in January. You can view a recorded version of that on our webinar section at wcb.ny.gov. So as we continue to work on implementing improvements for healthcare providers, we're committed to increase communication with providers, such as this webinar and targeted emails. The board recently added a provider requirements page to the website. In addition to sharing the latest news, this section also walks providers through everything they need to know, from getting started in the workers' compensation system to treating injured workers, billing for services, and more. You can visit the board's website at wcb.ny.gov, select the provider updates quick link on the provider page. I mentioned earlier, the board has also updated the medical billing dispute section on the website to include arbitration scenarios and recommended action for providers. And we are also committed to regular engagement regarding onboard. As primary users of the new system, your input engagement in the project is very important. As I mentioned, we've done a number of enhancements thanks to your input, so please continue with your feedback there. For more information on onboard, you can visit the website at wcb.ny.gov/onboard. Resources include a walkthrough of the registration process, video tutorials, and recorded presentations for providers. For more information on the CMS 1500 forum, including a list of XML or online submission partners and discontinued forms, please visit wcb.ny.gov/CMS-1500. We also have a dedicated mailbox to answer all questions on the CMS 1500 initiative, and that email address is cms1500@wcb.ny.gov. Please note there's no hyphen there. If you have provider-specific questions, you can call the helpline at 800-781-2362 or email mdo@wcb.ny.gov. You can also find the latest provider updates on the board's website. Just visit wcb.ny.gov and select the provider updates quick link on the provider page. You can stay informed by subscribing to get board notifications straight to your inbox at wcb.ny.gov. Just select the Get Notifications on the bottom of the homepage, and you can choose the topics you'd like to subscribe to. You can also follow the board on X, formerly known as Twitter, Facebook, Instagram, and YouTube for board news, project updates, trainings, and more. I want to really highlight that YouTube page, as we do have recorded versions of this webinar. We will be updating this webinar and putting that on our YouTube page as well, so you want to check that out. And at this point, this is the end of the presentation. I do see we have a lot of questions that have come into the mailbox, so I'm going to hand it over to our MDO team to handle those questions. Real quick, I want to mention, someone had asked earlier, we will be providing you with a copy of this slide deck as well as a recorded version. The recorded version will be on our YouTube page, and the slide deck will be on our website, but we'll also email you with links to all of those things. So just make sure you're signed up for email notifications so you know when those are available. At this point, I am now going to turn it over to our subject matter experts, and they will take a look at your questions and answer them.
Thanks, Adam. This is Dr. Tachi. I'm going to jump in on the first couple of questions. First of all, there was a very specific question about a very specific CPT codes usage. It was not really part of the webinar today, and I'm not sure it's a broadly applicable question, so I would encourage that individual to email us directly at the MDO with the email address that Adam provided, and we'd be happy to reach back out to you either by email or telephone and walk you through that answer. Similarly, there was a question regarding a surgical procedure that was reportedly authorized. I'm guessing it was perhaps granted without prejudice. that subsequently had a billing dispute, perhaps due to a legal issue. There was not really enough detail in that question for us to answer it now. And again, it was a highly specific question. So again, I would encourage that individual to email us directly at the email address that Adam is sharing. And somebody from our team will either email you back or call you back and work through that issue as well. And then finally, not finally, but there was also a question related to delegates not necessarily being familiar with all of the MTGs and incorrectly using the none selection on the drop-down when submitting a PAR. So first of all, it's very important to reiterate that the delegates entering PARs on behalf of providers is permitted really as an administrative convenience to the provider. The things that are being requested in the prior authorization requests are supposed to be reflective of the provider's clinical judgment. So the provider thinks that a patient needs a particular diagnostic test or surgical procedure or medication, etc. It's that clinician's clinical judgment that is driving that PAR and all of the elements of the PAR. So while it might be convenient for the delegates to be familiar with the MTGs, etc., as well, there should be no mistake that it's not supposed to be. It is not supposed to be the delegate's clinical judgment. It is the treating provider's clinical judgment that is reflected in the PAR. So whatever gets submitted electronically, again, it's the delegate's able to do it as a convenience to the treating provider, but that is the treating provider's judgment. There was a second component to that question, and it was reiterated in a couple of other questions, etc. And that is that there have been notices. There are notices that inappropriate use of the none drop down may result in disciplinary action, and that's too sort of broad. And so the question is, well, what type of disciplinary action, right? So, and that's too really broad of a question for us to be able to answer here. Certainly more often than not, the assumption is that when a provider is using that drop down, that none selection, if it's incorrectly used, then we ask the provider about the use. The provider explains, and if it was an honest mistake, we provide them guidance, and we request that they correct that honest mistake moving forward. If they don't correct it, then we have to re-engage and work with them about why is it that you haven't been able to correctly, because the assumption is that providers will correctly enter PARs, etc., into the system and correctly classify either the MTG that the PAR fits into or the type of medication that's being requested, etc. But there can be disciplinary actions. There may be instances where it may be performed nefariously, right? There may be some adverse reason why the none is being used. And if that were the case, and if that behavior were to be identified and continued, then there would be disciplinary action associated with it. But again, we like to give everybody the benefit of the doubt. And our first interaction just asks the provider to explain, and is a constructive, helpful correction as to how the none drop-down should be used. And then the assumption is moving forward that provider and or their delegates will use the drop-down correctly. With that, I'll open it up to some other folks from our MDO team.
Thank you, Dr. Tachi. This is Paula Rausch in the bar unit. We have a question from somebody that said, if the body part is established, then I send my request as a confirmation PAR, and it gets denied that it should be a variance PAR. So first, I'd like to just clarify that the PAR type is not related to whether the case is established or not. A confirmation PAR is an optional PAR type, and it's only used if the patient's clinical picture meets the criteria that's noted in the guidelines for whatever it is that the proposed treatment or testing or surgery is. A variance PAR is required for anything that does not meet the criteria in the guidelines. So if you're submitting a confirmation PAR and the attached supporting medical or the medical that's in the medical necessity field does not support that patient's clinical picture actually meets the criteria for whatever it is you're asking for, it should have been a variance and it will get denied as a confirmation PAR. There's another question related to whether NPs and PAs that see patients under the supervision of a doctor can submit their own medication PARs that they prescribe. The answer to that is yes. Out of state or workers' comp authorized providers who are PAs or NPs may submit their own medication PARs for patients that they are treating.
Thank you, Paula. I'll take the next few. There was a question with respect to the telehealth regulations as to how they apply to behavioral health services. And the telehealth regulations were designed to provide behavioral health providers a bit of flexibility in delivering care as long as there's no added benefit to conducting in-person visits. And specifically for psychologists and licensed clinical social workers, telehealth is typically permitted for the first and subsequent visits, and that does include group therapy, and that's regardless of the clinical stage of the injured worker. So for behavioral health, remote visits may take place unless the patient himself does not, wants to be in person, or there's another reason or some sort of undue risk or hardship to the injured worker. And I'll just note that the treating psychologist or clinical social worker must document the reason for the use of remote telehealth visits in their medical narrative of the report. There was also a question with respect to the CMS 1500, the electronic submission of CMS 1500. And carriers or payers must be accepting your electronic submissions of CMS 1500. That is, they should be accepting that. So let us know if you continue to have problems in that respect. With respect to billing, there was a question regarding the timing after an award, after an HP1 has been submitted and the board has issued an award in favor of the provider. Payers typically vary in terms of payment turnaround times, but there is payers must pay within 30 days of the award being issued by the board. So if payment's not made within 30 days, there is the option of filing a judgment. But again, payment times do vary, but it is 30 days. One here. There was lastly, on my end, there was a question with respect to chiropractors and our CME courses, the CME credits. Chiropractors can certainly submit certificates of completion for whatever courses you take to the specialty organization that chiropractors normally, wherever you normally receive your CME credits, you can certainly submit our certificates to that organization for credit.
There's a question, do you have any plans to allow for providers to check on the status of an HP1 that has been submitted, or the status of a C8.1, et cetera, in onboard? And those are good questions. I think it's important to realize that what we're working within right now is the first big phase, the first couple of big phases of onboard, and there are plans in the work to significantly expand the platform, perhaps for the HP1 tracking, et cetera. So it's a multi-year process, and the platform itself will be significantly expanded over the next few years.
Hi, this is Paula again. There's a question on where you can find the amount of automatically allowed PT visits following surgery. Frequency and duration of physical therapy are outlined in our medical treatment guidelines. Anything outside of what the recommendations are would require a variance. So you'd have to look at the individual guideline for that information. There's also another question asking about the C27 form. The C27 form is an obsolete form. Medically necessary care can be provided and then billed to the carrier. So there's no form to submit in advance.
All right, it is getting close to 1 o'clock. Before we sign off, I do want to reiterate, we are going to be sending you a copy of this slide deck as well as a recorded version of the webinar. Make sure you're signed up for email notifications so you can get that message when they're available. If you are not already signed up for email notifications, just go to our website, wcb.ny.gov. Scroll down to the bottom of the homepage and select Get WCB notifications. Again, you get to choose which topics you'd like to subscribe to. We will not inundate you. We promise that any information we send is pertinent to you as a provider. And you will also get updates on future webinars like this one. So with that, we are going to go ahead and sign off today. I want to thank you all for joining us. I want to thank our subject matter experts to taking the time to answer your questions. Always appreciate it. Before you sign off today, you are going to be directed to take a little survey. A couple quick questions. We want to know how we're doing. We appreciate you taking the time to fill that out. Let us know how we can improve these webinars, what you like about them, what you think we can improve on, anything you think that will make them better. We always appreciate your feedback. Also, again, we do distribute information via social media, so make sure you're following the Workers' Compensation Board on Facebook, X, Instagram, and YouTube. Again, I want to really, really push that YouTube page. You can view previously recorded versions of these webinars, this one once it's updated, as well as any other workers' compensation presentations we've done in the past. So with that, we're going to sign off. I want to thank you again for joining us, and please enjoy the rest of your afternoon.